Okay. Good morning, everybody. It's still just morning, and I'm afraid it's not a good gig to be speaking after Jerry. And those of you who know me well know I'm a Leslie. So thank you to Susan and to Gillian with the J for asking me to speak today. So all of you here know what multiple sclerosis is, but just to do a little quick refresher, it's a central nervous system disease. It involves your brain and spinal cord, and there are two major pathological components to it, inflammatory and immunological. This is a demonstration really of what inflammation is. And the importance of our immune system in MS. So with the immune system in MS, what's involved is that various cells are activated. They then cause inflammation, and this then damages the myelin sheath, which leads to the pathological process that we're familiar with. This is another cartoon of the inflammatory cascade, and the importance of looking at something like this is that it explains to us how our various disease modifying agents work. Some will work on the immune system, some will work on the inflammation, and what we're really hoping for is eventually something that will help to heal the demyelination process. So what causes MS? This is something that everybody asks when they come to see me, and it's a multifactorial illness. There are definite contributions from the environment, from your genetic susceptibility, and as made Morning Ireland during the year, is definitely there's a role to be played by infection. What each of these contribute to the diagnosis is different. Genetics actually gives a very small proportion to the condition, infection and environment probably more. The environmental cause is something that's dear to our own hearts here in Ireland, and today is one of those days that's good for us for our vitamin D and sunshine. And we know that vitamin D is very important in reducing your risk of a relapse in MS. There's an inverse relationship between your risk of relapse and the level of your vitamin D, and hence why you see your doctor and they say to them, why are you taking your vitamin D, and the importance of taking it. We know that the incidence of MS rises as you rise from the equator up to the north, and the reason for this seems to be part of it is our Celtic heritage, and part of it is the lack of vitamin D in people's diets. So there was an Irish study, and what that showed was that the rate of relapse in MS varied whether you lived in Donegal, Dublin or Wexford. So as you can imagine, if you live in Donegal, we get less sunshine than the people in Wexford do. So there was more relapses of MS in Donegal than in Wexford. And in Dublin, it was a neutral situation, probably due to the fact that most people at that time when the survey was done, the wealth of the population was greater in Dublin and more people went on sun holidays. As we know now, they all come to Kerry to fly to Faro because it's a much nicer airport. The role of the Epstein-Barr virus is very important. We've known for a long time that Epstein-Barr virus is associated with the risk of developing MS. And what the veteran study in the States showed very cleverly was that this is something that is indeed true. So it went from being a feeling to a truth. What they did was that all the recruits into the American armed forces have their bloods done when they join, and then every year thereafter. They then showed that as time went on, the people who seroconverted to Epstein-Barr virus, so developed antibodies in their blood to the virus, that those patients became 30 times more likely to develop MS. It has to be also said, though, you can have infectious mononucleosis or Epstein-Barr virus and not develop MS. It has to do with your immune system, and in the people who don't develop MS, what are called their natural killer cells work more effectively to clear the virus than in those people who do develop MS. So it's not simply you get Epstein-Barr virus, you get MS. As I've said earlier on, there are other contributions. So, for example, your genetics. The other thing is, it's another thing for us Irish people to be able to blame their mammies. If your mother had MS or someone in your mother's family had MS, it slightly increases your risk of having it. And the other factor that's involved are what are called epigenetic factors. Now, these are much more complicated than the straightforward, if you have a gene, you get a disease. So, for example, we know that if people in this country, cystic fibrosis is a very common condition or a common genetic condition. To get that, you need to get a gene from your mum and a gene from your dad come together, cause the illness. But there are lots of illnesses that are caused by epigenetic factors. So, for example, people who develop diabetes, it has to do with their diet, it has to do with the fact that they don't exercise, and then what happens is various genes switch on, and it's a bit like a clockwork mouse. All the cogs come together and then you develop the condition. And as with any autoimmune condition, women are going to get it more than men. Part of that is because we've been blessed with the ability to carry a baby. When you carry a baby, half of its genes are not yours. And so in order to accommodate that, our immune systems are set up in a very different way to a man's. And as a consequence, we're at greater risk of lots of autoimmune conditions, not just MS, but things like lupus, vitamin B12 deficiency, celiac disease, there's a long list. So how do you make a diagnosis of MS? Well, the diagnosis of MS is based on a multiplicity of things. It's based on the story that the patient brings to the doctor in the clinic, and it's also based on when you physically examine somebody and then proceed to do an MRI scan, examine the spinal fluid, and sometimes do visual or somatosensory evoked potentials. You don't actually have to do all of the above to make the diagnosis. And for me, one of the wonders I have in every day of my practice, and extending, as my son would say, back into the last century, where when I worked in Galway, I remember John Moran, who's still alive, a neurologist. He actually paid for somebody to have their MRI scan done in Dublin because at the time there was no MRI scanner in Galway. Like, that's kind of fascinating, given that there's probably 4 MRI scanners in the county of Kerry now. When I was a junior doctor in St. Vincent's, we were given what are called purchase orders to get MRI scans. They happened on the first Tuesday of the month. And nowadays you see people queuing up for tickets to Coldplay. Well, I used to queue up for a purchase order for an MRI scanner. And it got earlier and earlier. The office opened at 8, and generally if you were there for 7, you might get 2. So now it's wonderful. Your GP can order it, I can order it, and there's no limit on the number that you can have. Spinal fluid is helpful in making a diagnosis of MS, but I think why my job is secure for a while from artificial intelligence is that it's about the interpretation of the results. People can have what are called positive oligoclonal bands in 70% of people with MS, but 30% of people who have MS don't have them. So it's about putting together the pieces of the jigsaw, the patient who tells you the story, the person who tells you the story, the scan, the CSF, and as I say, other tests sometimes are helpful when you do negative tests, blood tests to make sure you don't have lupus, blood tests to see if you have unusual forms of MS like aquaporin 4 or perhaps anti-MOG. So this is an MRI scan. This is an MRI scan that's typical of MS. But of course, it would be all wonderful if they were always typical of MS. And sometimes they're not. And sometimes people will have had an MRI scan done just because they have headache, and it will show signs like this. And sometimes people will have an MRI scan that shows white dots, and they're non-specific white dots. And then that's, again, preserving my job for another while, because I have to interpret the scan in the presence of the person who presents with the symptoms. This one is easier. This is an MRI scan of your cervical spine, and you can see the abnormality with the red arrow, and that's an area of inflammation. And again, nothing is always in medicine, and nothing is never in medicine. But if you have something like this, then almost certainly this is MS. So how do you manage MS? Well, the management of MS is a interaction between the doctor and the patient. So there are two people in how we manage MS. And that involves medical management, which involves discussion of disease-modifying treatments, and then also symptomatic management. So this is a cartoon explaining why disease-modifying agents are very important. So this is mapping treatment with disability against time. So this is the natural course of the disease. So before we had disease-modifying treatments, all we had to offer patients who were diagnosed with MS were steroids and sympathy, because there was nothing else to give a person. Now, that being said, 50% of people who have MS back in this time, 25 years after diagnosis, walked without any support. So there are a cohort of patients with MS who are going to do very well whether there's medical intervention or not. The challenge, of course, is we don't know who that person is, and to date we have no tests that will allow us try and identify that person. So effectively we don't have what's called a predictive or prognostic biomarker. So because of this then, when the disease-modifying agents became available, they first became available suggesting that we should use them when people had clinically definite MS, had 2 relapses in the last year, and were able to walk greater than 100 metres unaided. Now, I would be very hopeful that most people here in the audience have probably never had 2 relapses, not to mind 2 relapses in the last year, because that's the significance that disease-modifying agents have made. It's unusual, thankfully, now to have a relapse, and certainly I would consider us very unlucky if our medication wasn't working such that you had 2 relapses in the last year. So the theories now are get in there early, start your treatment as soon as you're diagnosed, and that's going to reduce your risk of disability into the future and reduce your risk of relapse. Now, I'm not going to go through all of these, but isn't this wonderful? And this isn't exhaustive. Like, to me, it is amazing to think that there are more than 20 treatments for MS now. And what's wonderful about it is it allows person-centric treatment. So it means that the treatment that you're going to be offered by your neurologist is going to be taking into consideration who you are and where you are in your life. It is my practice that I will tell a patient when they're diagnosed with MS, these are the treatments that I'm considering, and give them information on these treatments, and then ask them to come back and see me with their questions, or see Caroline when we will talk about which drug we are going to choose. I did this quite early on in my career, and one of the local GPs was visited by the patient with the arm full of leaflets. And she said, "This is absolutely ridiculous. This is like me saying, what colour antibiotic do you want for your infection?" But I disagree. I think MS or any chronic illness is a partnership. It's a partnership between me and the patient. At different times in that relationship, it might be me making the decisions, and at other times it might be you that's making the decisions. And so it's very important that you're invested in the treatment that you choose that works best for you. I'll give you an example. I have a patient who's very involved with a hurling team in a county not here, and I'm from Galway. He had MS, he had been on an interferon for a long time, but the time had come to change. He was getting injection site reactions, and his MRI scan showed some changes. So I wanted him to go on natalizumab, Tysabri. It's once a month, but he said to me, "Sundays don't suit me." And I thought, Sundays don't suit you? It's the rest of your life. And he said, no, hurling matches on Sunday. And so as a consequence of that, we discussed what we would do instead, and instead of that, he's on ocrelizumab. So while I might have thought it was the best thing medically he went on natalizumab, the best thing for him personally was to go on ocrelizumab. Now, if I thought medically it wasn't the right thing, I would probably have put the glasses to the end of my nose and said no. But as I say, it was the appropriate thing for him. Equally, for younger people who are diagnosed with MS and want to go travelling, I love this. I was born in an era where there wasn't a gap year, but they all do it. And therefore, say a drug like Mavenclad might be much more suitable because it can be given at an annual interval. So all of these things are taken into consideration, and there's no point in me saying to you, this is what you have to do. I have to give you the options, you have to think about it and come back and talk to me. So how do you make decisions? Well, you can make decisions based on age, and of course I'm putting my hands up now and saying I'm not ageist, I'm not anythingist in this world. It may depend on whether you are biologically male or female. The reasons for that being that there are some drugs that even as men you can't get pregnant on. So if you are, for example, a person with MS taking Mavenclad and neither as a man nor a woman should you become pregnant. And that needs to be, can cause kind of challenges when you think of the age group that perhaps we use Mavenclad. Pregnancy is also a special circumstance. So for people who are wanting to get pregnant, then you might like to have them on medication that is safe to become pregnant on. Or perhaps you don't want them to go on medication that if you take them off it, you run the risk of having a relapse. Thankfully, there's been sufficient studies now to show that, for example, if you are undergoing fertility treatment, there's no reason that that will interfere with your MS. And equally, some of the very high and powerful acting drugs can be used throughout pregnancy. We also have to take into account other illnesses. The problem, I think, with a lot of studies is they don't happen in what I call real patients. They're the ideal patient. They're aged between 18 and 50. They are a perfect weight. They don't have any intercurrent illnesses. Well, that's not the real world, is it? And so when we start using drugs like this in people who have, for example, diabetes, so you're already taking 3 subcutaneous injections a day, are we really going to add in another one and increase your injection burden? Or, as happens because the vast majority of patients with MS are women, you run into problems when patients develop breast cancer. So how am I going to manage your MS now in the setting of breast cancer? Or if you are someone who is very unlucky and has multiple autoimmune conditions. So we have one patient who has Crohn's, has sacroiliitis and also MS. And natalizumab was a perfect fix for that person because it actually can be used in all 3 illnesses. So these are all challenges that we meet at all times that really we don't have a chartered course. It's very much an individual course and one that has to be decided not just by me, but by you and I working together. In fact, one of the first people in the world who had a baby on Tysabri was one of our patients. So this is another cartoon reminding us that there are all sorts of things happening in the situation of MS. So you certainly have disability, and most people, when I make a diagnosis of MS, say, does that mean that I'm going to be in a wheelchair? And I'll say, I don't know, but what we will do is work with the medications in such a way to make sure that you aren't. All of the drug trials up until now focused predominantly on disability, as in physical disability. But we're now much more aware that in addition to physical disability, what we have to do is prevent what's called brain atrophy. So what we're trying to do is also decrease the risk of developing cognitive problems as a part of your MS. And increasingly also recognising that people can present with MS with a cognitive problem. So a person can come in saying, I'm not thinking as well as I used to. And I'm not talking about the brain fog term that is kind of overused now. It's used in post-COVID, it's used in menopause. And when a term like that is overused, it loses its meaning. So in this circumstance, the newer drugs are all being measured against developing and preventing brain atrophy. So it is wonderful to see that in an illness that 30 years ago there was very little to be done, not only now are there multiple drugs that we can use, but also we're concentrating on the whole person. I'm just going to mention that there are many, many symptoms that occur with MS, and many things that we can use to intervene. So for example, if people have increased tone in their muscles or spasm, there's a whole range of medications that we can use. But let's now concentrate on wellness in MS. In particular, let's start with one of the conditions or one of the problems that people complain about, which is anxiety and depression. Now, I'm definitely not going to talk too much about that. Jerry has spoken very well and eloquently about it, but I would agree that I think it's very important to use your own inner resources to try and manage it. But equally, if that isn't working, then there are medications that work very well and can make a considerable difference to your life. We are always very reluctant to take medications for our mental health and feel that sense that we should be strong enough to be able to cope with it ourselves. Well, you wouldn't think of curing a pneumonia by just kind of curing it yourself. You'll take antibiotics. Antibiotics work very well. Sometimes you need medications to take you out of a situation with anxiety and depression. And of course, my favourite, mindfulness. I'm afraid I'm not known for my love of mindfulness. I call it being self-aware. I call it being in the moment and being present to yourself at that time. I know you're going to be spoken to about food later on, but it is very important. One of the risk factors for severity in MS is being overweight. And so it is important to eat sensibly. Everything in moderation, particularly alcohol. And of course, those of you who know me well will know that I'm a passionate anti-smoker. And again, it is something that is within your control because people who smoke have more active MS than people who don't. Exercise is also terribly important. In fact, it's not just cardiovascular exercise, it's also strength and conditioning. And again, you have to modify your exercise program for who you are. If it is a thing that your legs aren't very strong, then it is very important that you keep your upper body strength. It is about being able to manage what you've got in the moment. I have a patient who is now in a wheelchair, but says that her legs served her well, and when they worked well, she used them well. She played basketball to a very high level, and she feels that that stands to her because she also keeps her upper body very strong. So I don't kind of buy, I'm not able to do it. I'd say we have to find a way for you to be able to do it. Fatigue is a major problem in MS. 75% of people will report some sort of fatigue. It is shown that the more you exercise, the less you'll be fatigued. And people find that very irritating when you say it to them. And they say, I'm really tired, I can't exercise. Well, it's kind of one step at a time. And instead of kind of doing an excuses to all the men that are here, the boy thing where you go couch to 5K in a night and then don't run ever again, what you have to do is build it up slowly and also recognise that exercise, lifting, 2 kilograms 10 times a day is exercise. Equally, if you walk 200 metres 5 times a day, well, actually that's a kilometre. And if tomorrow you do 250 metres 5 times a day, in 2 weeks you're up to 2 kilometres a day. It's slowly you do it, slowly you build it up, and then that stands to you. The MS Society runs the FACET programme, which is very well worth doing, and they'll do it with you virtually as well as in presence. So what's the future in MS? Well, thankfully the future in MS is again looking rosy. We're no closer, unfortunately, to finding out what causes MS, but we certainly have a lot more disease-modifying agents that are available. We have also noticed that the trials that are happening now are promoting more towards prevention and more towards remyelination. Statins that you're all familiar with, that trial is due to report this year. There are some side effects from statins that can cause problems, but overall it's looking like a positive trial. The metformin, which is a kind of a drug that's trying to find its home. It's used a lot in diabetes, it's used in polycystic ovary disease, it's now being used in MS, and that trial is due to report this year as well. The tyrosine kinase inhibitors, unfortunately, have a pause put on them. Tyrosine kinase inhibitors were a unique form of treatment, and they were going to be used in patients who have this unusual thing called progression without relapse. So these are patients that have MS, they come in to see me, the scan is fine, but they're saying to me, I'm not fine. And so what seems to be happening there is that there's inflammation happening in a different form, and the tyrosine kinase inhibitors were found to be quite useful for these patients, but unfortunately a signal has come up where there's abnormal liver function tests on these drugs, and as a consequence there's been a pause put on them. Now, we may well do very well. People might remember that with natalizumab there was a pause put on it because of PML, but hopefully this group of drugs will come back. Remyelination seems to be happening, at least in the poor mice. So in the MS mice who have demyelination, they're being fed this cytokine, and when they're sacrificed, remyelination has occurred. There seems to be very little side effects from it. So this is a first. This is the first time we've actually seen something that is promoting remyelination, and that to me gives great hope. So repair in MS, it looks like it's on the horizon. So we may be in a position where when a person presents with MS, that we're going to give them a drug that will help with repairing what has already happened, and another drug that's going to prevent it getting worse in the future. And of course the prescription for exercise, vitamin D, and to stop smoking. So in managing MS, it's not what I say, and it is very important that I listen to what you say. What we have to do is manage this condition together. For me, I can give you the advice on the most appropriate disease-modifying agent. What I have to hope is that you will then commit to it, have the blood tests done, have the scans done, because all of that's important in reducing the risk of side effects. And then these are the things that you can do. Not smoke, maintain a healthy weight, exercise, take your vitamin D, engage in mindfulness, and engage with the MS Society. One of my patients, when I told her she had MS, remembers me saying to her, yes, you have MS, but it doesn't change the person who came in the door to me, and you can do anything that you want to do. Any questions?
I have one question. I'm going to laugh now.
Go on.
Okay, so just this isn't working yet.
So you can talk.
Menopause, the lovely menopause, HRT, does that affect the drugs that people could be on?
It doesn't. The HRT, there's no reason why you can't be on HRT. If you like, it's quite similar to, in the same way that if you're pregnant, you can take hormones. In fact, at one time there was a study being done on estrogen as a possible treatment for MS, because of the observation that during pregnancy you're at decreased risk of a relapse. That was abandoned because of the high risk of clotting, but that was an estrogen effect, not an estrogen interfering with MS.
About the vitamin D. Do you have to take that with milk? It's on the radio every day.
No, the vitamin D that's in milk is fortified with vitamin D, but the amount of vitamin D that's in that, you'd have to drink an awful lot of milk to get enough vitamin D. Vitamin D is best taken as a supplement prescribed really by your doctor, because the vitamin D, now some of the health food ones you need to check how much is in it. Vitamin D that's in multivitamins probably isn't sufficient. You also need to be careful because if you are on medication to either treat osteopenia or prevent osteoporosis, there will be vitamin D and calcium together. So you have to be careful not to take too much vitamin D. It is a case of too much of a good thing is bad for you, because if you take too much vitamin D, you're at risk of this funny thing called ectopic calcification, where you get calcium deposited where you don't want it. There have been studies done in the Scandinavian countries where they were trying to figure out which was the thing that was better for people with MS, sunlight or vitamin D. And unfortunately, I can't prescribe flights to the sun for everyone. It's vitamin D.
Hi, just a very quick question. Vampira, is there anything on the horizon to tailor that to improve it a bit?
There isn't, that's an unusual drug. So Vampira is 4-aminopyridine. It's a drug that is used to increase the contractility in muscles and is used to improve gait performance in people with MS. It's also used in other conditions where there's a problem with how nerve and muscles talk to each other. For example, a condition called Eaton-Lambert syndrome. But to date, there's been no changes or modifications of it.
Anyone else? Question?
Sorry, the remyelination that you were talking about there at the end of your presentation that was tested on mice, is there any time frame for human trials or anything like that?
No, it's a phase 1 trial on the poor mice, but it is a start. Like, there have been lots of drugs that have been tried to promote remyelination. One of the very early trials on Tysabri, there was some evidence that there was remyelination, but that was never substantiated.
Yeah. What treatment plan would you have different for patients with relapsing, remitting and primary progressive?
That's a hard question. At the moment, there's only one drug licensed for use in primary progressive MS, and that's ocrelizumab. So ocrelizumab is a CD20 inhibitor, so it works on your B cells, and it is licensed in primary progressive MS. The challenge with primary progressive MS is really deciding when someone has it. It probably will transpire to be a different type of illness to relapsing and remitting MS, because the vast majority of people who have primary progressive MS are men, usually present in their 50s, usually have what's called an EDSS of 4 or 5 at presentation. So they are already have difficulty walking by the time they come to see you. Sometimes their problems have been written off to maybe arthritis or back disease, and the neurologist may be the 3rd or 4th doctor that they've seen. And so it is my opinion that in the future that will be a different illness and we'll be using different medication.
Anyone else?
Great. Thank you.